Okay. Can you see my screen?
Yes. Yes.
Perfect. All right. Thank you, guys. It's great to be with your group. We look forward to developing a relationship with you, with the WFNS. Honored to be, to be speaking with you today. I'm going to time myself, so that way Professor Gaffa starts exactly in half an hour. 1 or 2. Okay, good. So what I'm going to talk to you just briefly today is my journey in brain bypass surgery, and to take you through an exercise to see how you think through this process. So we'll start with a case and see what you guys think. Okay. So this is a lady that was sent to me because she had a problem with posterior circulation ischemia. Many of you medical students realize there's a big problem here. You see, this patient this is aortic arch, no blood supply to the left arm from the arch. This is all occluded here. So what's happening is that this is the brachiocephalic trunk on the right side, okay? So she has, since there's no flow to the left side of the neck, there is the carotid artery, the common carotid artery is coming off the arch here, but it is occluded. The internal carotid artery is completely closed. There's no internal carotid artery flow to the brain. When you come to the right side of the head, you have the trunk, you have the internal carotid, the common carotid artery, but there's no flow. The internal carotid artery is totally closed. So the two internal carotid arteries are completely occluded to the brain. The only artery going to the whole brain out of the 4 is the right vertebral artery going to the brain. Okay? So we've got a problem. So this lady's having a lot of ischemia, lack of blood flow, especially to the posterior circulation. Why is this? When you follow the flow of that vertebral artery, the only artery going to the brain is supplying the whole brain. Then, as she uses her left arm, the vertebral artery then goes back down from the brain to supply the arm with blood. So you see, instead of 4 arteries to the brain, she has only 1 artery supplying the whole brain. And then because the left arm has no blood supply, then the blood goes back down to the vertebral artery to supply the arm with blood. So we got a huge problem here, okay? So she can get, she's been treated with anticoagulation, aspirin, everything. She's progressively getting worse. So the question to you is, how do we deal with this problem? How do we bring in more blood flow to the brain, to this patient? So I don't know who's on the, I will come back to this. Let me continue. I want you to think about how you're going to help this patient. How can this patient get more blood flow to the brain? This is my journey. I'm going to use this case as an example to my journey in bypass surgery, okay? Let's move. So this is a problem. Does everybody understand, the students? Do you understand what the problem is? I want to make sure everybody's understanding and there's no question, okay? All right. We got a big problem. I mean, like, in the US, we say, Houston, there is a problem on the shuttle. This is that kind of problem, okay? This lady is at risk of major stroke in the brain. But she's not getting blood flow to the brain. I just want you to know these arteries are chronically occluded, these carotid arteries. I mean, this is occluded for a long time, okay? And the vertebral artery is open, but unfortunately, he's stealing blood from the brain to give the arm with blood on this side. Let's go back in history. What are the ways to bringing blood flow to the brain? I go back to my mentor, who is the father of modern neurosurgery, Professor Yashigo. On August 7th, 1967, he performed an operation, the first of its kind in human beings, where he took the superficial temporal artery from outside the temporalis muscle and attached it to the middle cerebral artery in a patient who had occlusion of the left middle cerebral artery from stroke. Not as bad as the case I showed you, but the left middle cerebral was occluded, and this was the first time ever this operation was conducted, okay? So this is the beginning, just the beginning, the first stages in the cave for us in neurosurgery, using the early instruments in bypass. What he showed you here, what Professor Yashigil did, is a big craniotomy, taking the superficial temporal artery, attaching it to the brain. While I'm talking to you, you need to start thinking, is this the operation we need to do this patient? I want to talk to you, see what you think, okay? So this is bringing the STA and supplying and attaching it to the brain. What he's talking about is what we call low flow bypass surgery, where you take the superficial temporal artery, attach it to the brain surface, to the MCA to bring in blood flow to the brain, okay? So as we develop in neurosurgery, we continue to develop the procedure. See, the original procedure described by Yashigil, the way it's done, you take the superficial temporal artery, and then you make a craniotomy, then you attach this artery to one of the branches of the MCA to bring in more blood flow, okay? So what I did is, because instead of having a big craniotomy, we thought, since we have now image guidance, we could do a very small operation, minimally invasive. You see, I know where my donor branch is right here. I know where my recipient branch is based on the skull CT scan. Well, then if I know that, I don't need a big craniotomy. I could do a very small opening and attach this artery to that artery. And you see, I'm using the system before surgery, isolating where I'm going to attach. You see, I use a very small opening, like a quarter size, 2 centimeters. So this is attachment of the superficial temporal artery to the middle cerebral artery to bring in blood flow. So this was our early experience showing that you could do this operation very, very small. I do this with the patient awake. Very tiny operation, bring in blood flow to the brain, okay? So this is our early involvement in bypass surgery. For you, the students, what you need to do is this. You need to learn under the microscope the simple steps. You see here, I'm teaching my students and my residents on a rubber tube. You sit next to a microscope. You take this tiny instruments we call jeweler's forceps. If you're right-handed, you hold this loop with your right hand. You make a loop. Then you put the loop through. You pull this way, that way, okay? Next one, you hold with your left hand through the loop, you put your jeweler forceps, boom, okay? See that? You guys learn how to tie in surgery, closing skin and stuff, but this is different, okay? This is under the microscope, all right? So here, this is a training we're gonna be doing for you guys in various forums with the World Congress for Medical Students we're doing now. We're going to be training you how to do this stuff. So you learn to have your hands to be good. You learn how to hold instruments under the microscope, do simple maneuvers like this. These are the simplest maneuvers that teach you stepwise how you do this under the microscope using tiny suture. Okay? So this is what we want to train you to do. Okay. So what are the examples of this? This is a patient who has middle cerebral artery occluded, like Professor Yashigil case, okay? There's not enough blood flow to the brain, okay? So you see, I'm gonna use this superficial. So I take the superficial temporal artery, then I line it with color because it's hard to see around CSF. You see, I make a hole in. Now I'm making a hole in this M4 branch of the middle cerebral artery right there, through that tiny opening I showed you. Boom, making an opening, okay? You see that? Now I'm gonna put the different techniques. We'll teach you this stuff. We call the heel and toe method. We put the heel first, then the big toe here, 12 o'clock, 6 o'clock. Okay, technique I just showed you under the microscope. This is 10-0 suture. Very, very small, hard to see with the naked eye. Okay, technique I just showed you with the instruments I showed you. Okay, right there. Okay, so boom. Okay, you see how those are sutures I just taught you on the rubber tubing. Now you are doing it in a real human being. But first, you have to become an expert in doing this. Okay, expert in the rubber tubing, and before you start doing anything on human beings. Okay. Now we have a different problem, folks. This is a patient that was sent to me with a mass. Initially, somebody thought this was a meningioma. It's so big. But when I saw it, this was a massive aneurysm. It's like 9 centimeters. Remember, for the medical students, most aneurysms will be this size, like this dot in the human brain. This is a 9 centimeter aneurysm. Problem is, you cannot clip this aneurysm. You'll tear the aneurysm, you'll close the carotid artery. You cannot coil this aneurysm. You try to coil this, you're going to occlude the parent carotid artery. So now you have to think outside the box. What I have to do is replace this carotid artery, do a bypass, and close off this whole thing. Okay? Now, the tiny STA does not work. I need a big graft, like a big vessel to attach to the brain. Then I can close off this whole thing. What am I going to do? So when I came into vascular neurosurgery after my fellowships, the first generation of neurosurgeons, so first you have the generation of Professor Yashigul, then there was the next generation of early vascular neurosurgeons who started doing this high flow bypass. They were using the saphenous vein from the leg. I tried it a few times. The problem with the saphenous vein, it has a lot of valves. It can create a lot of problems. So I called Professor Yashigul, say, I want to do this high flow bypass surgery. And I've seen the heart surgeons use the radial artery. My professor at that time on my phone, I called him up. He told me, this is what I want you to do. I want you to go with your heart surgeons, scrubbing with them in many operations using the radial artery. See how they're using it. Then we think about using you can think about using the radial artery. So I spoke to the heart surgeon, who's my friend. I scrubbed in multiple heart surgeries using the radial artery with them, feeling it, whatever. Then I called Professor Yashigul, said, I think I'm ready. He said, go ahead. Go ahead and start, see what you could do with the radial artery. So I want to show you the surgery, how we do. This is different now. This is not that tiny vessel, the STA, folks. Now we're talking about the big artery in the brain, okay? So this is an example. This is a Sylvian fissure, frontal lobe, temporal lobe. Boy, what happened there? Can you still see me? Hello?
Yes.
Okay.
Yes.
So now
Yes.
I'm going down to where I'm going to attach my graft. So this was the initial operation. You see, this is a radial artery here. I took it from the arm. I'm in the neck of the patient, attaching the radial artery to the external carotid artery in the neck. Okay? So the suture we use in the neck is bigger because these are larger vessels. So we attach the artery to this external carotid artery in the neck to create a new blood flow to the whole hemisphere. Okay? So I'm attaching it. I'm doing my thing. You see, I'm getting very nice flow from the external carotid. Now I go to the brain. I'm going to do a small arteriotomy in the M2, M3 branch of the middle cerebral artery here. See, I'm opening the artery. Okay. I'm going to open it. I'm going to clean it with heparin, make sure there's no blood clot. You see, I'm putting a lot of heparin inside. Okay. Now I'm going to attach the radial artery to the middle cerebral artery. This is coming, all the way from the neck, okay? You see now we're using tiny suture. We're deeper in the brain. We're using longer instruments. You learn over time how you use really long instruments to do anastomosis deep in the brain, okay? You see right there. Just because of time, I'm gonna, move this along here a little bit. Anyway, So that patient I showed you with giant aneurysm had a radial artery placed. The whole aneurysm and the carotid artery was occluded, and now this artery is supplying the whole hemisphere through the middle cerebral artery. This was published as the first case in neurosurgery using the radial artery, okay? And I have to be very happy now because I teach this around the world. The majority of neurosurgeons in the world now who do this kind of surgery use the radial artery, okay? So these are the steps of my growth in bypass surgery to the brain. What's the next step? Okay. You see the stepwise approach, how I'm thinking as I'm going through my career. You see, this is a very big operation. You go all the way to the neck, big incision in the neck, long graft. The longer the graft, the higher risk of thrombosis. This is the physics of vascular surgery. The shorter the graft, the higher the success rate. So in my mentor's book, Micro Neurosurgery, Professor Yashigal, I used to read his book a lot and talk to him all the time. As I was doing that a lot, I used to see this artery here. So you see the bypass I did? I went from all the way from here to here, all the way from here to here. I used to see this artery. It's a maxillary artery. And then I was doing surgeries in the skull base, and I used to run into this maxillary artery. And I started thinking, what if I can do the bypass not all the way from here to there, but what if I go from here to here? Shorter graft, not such long incision in the neck, just a small incision to close the carotid at the end. What if I go from here to here instead of all the way from here to here? So this is 3D. You see, this is a maxillary artery sitting right below the temporal fossa here. You see, right next to me, right next to my craniotomy. So I'm thinking, okay, but if you are a surgeon, you're a scientist, you cannot just start next day, okay, I'm going to go do surgery. You know, there's a lot of steps. This has never been done before, okay? I spoke to Professor Yashigal, who said, go to the lab, figure out your idea. So we went to the lab. We did so many, my fellows and my residents, we did a huge project identifying the maxillary artery through the middle fossa, through the craniotomy, going down to find it. Then we had to get IRB approval from the university hospital to do the first case after we shown it can be done. This is the first patient ever to have this surgery. You see, we did the craniotomy. Now we are exposed the maxillary artery through the middle fossa. We attach it right there and right here. This is the first human being to ever have this surgery right here. You see, big graft, maxillary artery to the middle cerebral artery instead of going to the neck. This was published as a cover page in Neurosurgery journal. Then another big person, big master in the field, he's also a generation before me, one of the true masters in neurosurgery, Professor Spetzler. When he wrote his book in bypass surgery, he named this the Abdulrauf bypass. I'm humbled. See, we in our career, it's not what you do for yourself, but what people in your field credit you. He is the one who named it the Abdulrauf bypass, and this is how it's known in neurosurgery now. I'm humbled and honored by this, by the people who came before me who are giants and masters themselves. Okay, at the last few minutes I have left, go back to the case we started, guys. Now you're all experts in bypass surgery to the brain. I want to hear from you. What are we going to do for this lady? What are we going to do for this lady now that we have, you know, now you are all masters in bypass surgery. You know everything about it. I took you through my journey. You know what can be done, what cannot be done. So what are you thinking? What do you think can be done here to solve the problem of this lady? For those of you joined a bit late, let me show you again what the problem is. So we have a lady that came to me, sent to me by my neurosurgical colleagues. She has a lot of ischemia, lack of blood flow to the brain. The left side is completely occluded. She has no flow to the left arm. The right common carotid, internal carotid artery is occluded to the brain. No flow to the brain. I mean, the left internal, the right occluded also. The only one of the 4 vessels that's open to the brain is the right vertebral artery going to the brain. Okay? So the right vertebral artery supplies the whole brain. Then, as she uses her left arm, the vertebral artery steals blood from the brain to bring it back to the arm. We've got a major problem. Okay? So the question is, what are we going to do? Do we have any great ideas from our great group of colleagues, students here? What would you do?
MCA bypass.
Say that again. Who's this speaking?
Sir, Prashant Upadhyay.
Prashant, what do you think now? What kind of surgery are you going to do?
Sir, MCA bypass to the left side.
So you mean STA MCA? You mean the superficial temporal artery?
No, sir, because that superficial temporal artery will not be receiving the blood. So we'll do the contralateral MCA.
So you go from MCA to MCA.
Yes, sir.
How is that going to help you? Because there's only blood flow coming from the right vertebral. So if you went to her brain and you went MCA to MCA, the problem's still there because it's not only blood flow to the brain is a vertebral artery. It's not going to help you. Plus, the problem with this lady, if to do MCA bypass, to do temporary clipping of the MCA during the surgery, and as somebody who's so ischemic is very dangerous as well. Good idea, I like it, but I think that would be too risky, not going to help us. Okay, other students, tell me your great ideas after now you're experts in bypass surgery to the brain. Who's going to tell me? Only have 4 minutes. You got to be quick.
Dr. Abdulrauf, can I just confirm one thing before I answer?
Yeah. Who's this talking?
Marwan Jaber.
Marwan, please tell me.
Are both the common carotid arteries occluded? Both of them?
Both internal carotid arteries are included.
Okay. So,
but the internals, but commons are both are open.
So we would go common to MCA.
Okay, that is a reasonable option. You could say, okay, what I'm going to do is go to common, take a graft like the radial artery, common to MCA, common to MCA. Reasonable idea. You bring in a lot of blood flow to the brain. The problem with that is in this lady, because there is such lack of blood flow to the brain, when you do the anastomosis with both MCAs, you're going to stop the blood flow. Because she's so ischemic, the risk is very high during the surgery. Good idea. I like it. More ideas, guys. Let's do it before Professor Raffa gets upset with me and I'll go over his time. So give me another idea. Come on, guys. You're smart. You're experts now in bypass surgery to the brain. Tell me another idea, folks. Think outside the... I always tell you guys, think outside the box.
May I make a suggestion? Hi.
Who's this?
My name is Tara.
Tara? Okay, Tara, tell me your suggestion.
So when, as you focused a few times, we cannot use the MCA and occlude it.
I'm very concerned about using the MCA. That's right.
I would need a high flow bypass from external to internal if possible.
From external to internal. So our externals are open, okay?
Yes.
So how are you going to go? Okay, external. Which internal? The internals are closed here, completely occluded.
Yeah, I mean bypassing the closed area or the stenotic area, reaching to the distal part of the internal carotid and doing.
You mean in the brain?
Yes.
Yes, I think that's an option. You could say, okay, I'm going to do a high flow bypass, go from here or wherever, and go to the internal carotid artery. Okay.
And bypass the occluded area.
Yeah, bypass the occluded area all the way to internal carotid. Okay. So the other option is, Hara is saying, is you take the radial artery, you go from here to bilateral craniotomies, internal carotid artery. I think that's a reasonable idea. Big surgery, bilateral internal carotid artery bypass, craniotomies to the brain in a lady who's older, ischemic is a big step, But you know what, Hara? It's very reasonable. I like it.
Maybe we start unilaterally at first, since the
Yeah,
patient
always
already
do one
depending
side
on one
first, then
vertebral.
the other side. Yeah, I think that's reasonable. I think that's a reasonable idea. I want you to think outside the box, folks. Tell me another option that could be slightly less invasive for this lady, but can bring in more blood flow, a lot of blood flow. You got 2 minutes because before Professor Raffa gets really upset with me. Come on.
Can I go, doctor?
Who's this now?
Again, Marwan. Sorry.
Marwan, come on. I want to hear some new voices.
Can we fix the
Yeah.
occlusion to the left arm so when she moves or?
Yeah, you mean this whole segment? The problem with these, very good thinking, Marwan. The problem with these are chronic occlusions. You cannot, this would require a major thoracotomy, open heart, open lung surgery, but you cannot even fix it. If it was stenosed, yes, they could put in stents. But if it's occluded, there is nothing to do a bypass from the aorta to here for her. This too big surgery. I mean, this is, you know, the risk is totally out of the, so far, I think, you know, based on the things you guys have said, that would be among the highest risk. Among the things you've said, what Marwa said, probably on the lower risk standpoint. There's still one more option, guys. And you guys need to tell me one more option as to what I could do to help this lady. You know, tell me one more option. I want one more really option. Remember how I'm thinking. More blood flow to the brain, less invasive, less risky to the patient. That's the combination. Who else is here who's going to tell me? Come on now.
Prof said, bypassing another artery to the left side of the brain.
Say that again.
Bypassing another artery to the left side of the brain.
Bypassing another artery to the left side of the brain. Yeah, that's the issue we talked about with the MCA bypass. You know, we're going to have temporary occlusion of the MCA. Okay. All right. So this is the deal. Because my time is up, this is a homework. You
So
guys
can we
gotta-
do the
we got okay, hold on. We got Who's this?
Prashant Upadhyay.
Prashant, yeah, go ahead.
So one more thing. So like, can we go for the left subclavian to basilar artery bypass? So
Subclavian to
for the
bypass.
precommit
Yeah. So if we went through the subclavian to the basilar artery, temporary occlusion, even few seconds, probably she would not survive that. Just for all of you guys know, basilar artery, we'll talk about it someday. Temporary occlusion of the basilar, even for a few seconds in patients, is a disaster. Okay, guys, we're gonna meet again, I think soon in another major conference. You guys gotta think through this. Don't be talking to your vascular neurosurgeons. I want you to go and think and look at anatomy books and know how I think, how I, how I want this to be minimally invasive, and you guys give me an answer next time we meet. I'm over my time. Thank you very much for having me. It's my honor, and we will talk sometime. But next time I talk to you guys.
Listen, can you drop the question in the box, in the message box?
Okay. Let's see. What's in the message box? I don't see the message box. Okay.
Okay, thank you so much, Prof. Saleem Abdulrauf, for your legacy journey. I am very proud to open that discussion panel.
Oh, you want to have a discussion? Okay, we can.
Okay.
Yeah. I just want to make sure. Yeah, we can have a discussion, but I want the homework to be there. Okay. Okay. So Aswala Martins is saying, how about superficial temporal artery to the MCA? Yes. we could use superficial temporal artery to MCA both sides. The problem in this lady, I'm trying to avoid temporary occlusion of any MCA in her because she's so ischemic. Okay, so this is homework now. You guys gonna go think and come back to me, and please do not ask Dr. Giovanni, Professor Giovanni Raffa. Okay, you guys have to figure this out yourself. Okay, so now no
Please drop
cheating.
the question in the main
Yeah.
box.
Yeah, the question is how you're going to treat this. Imagine this is your patient. Imagine this is your mom, your grandmother, and how you want to treat her best for her safely. Okay, but we will not discuss this now because over my time. Alatar, we're gonna be having another session with you guys at some point. Then we're gonna come back and you guys tell me your answer. Okay.
Okay.
All right. All right.
Okay.
Thank you.
Bye.
Thank you.
Good evening, everyone. It's a great honor and pleasure to welcome Professor Giovanni, a distinguished neurosurgeon and internationally recognized expert in the field of neurosurgery. We are truly grateful for his time and willingness to join us today and share his valuable experience and insights with us. Professor, thank you very much for being with us. The floor is yours.
Thank you so much. Thank you for the kind invitation. It's really hard to me to speak after Professor Abdulrauf. His presentation was really wonderful, amazing, very interactive. I will move with a less interactive session. Let me check if I'm able to share my presentation. Okay, I have some issue, I think. Wait. Okay, I think I have to go out and enter again into the talk because I have to modify the system feature. I apologize for that. I'm coming back.
No problem at all. While Professor Raffa is coming back in, about the other stuff I asked you, is there any questions about bypass surgery? Not that specific patient, but the bypass surgery I talked to you about. Do you guys have any questions for me about anything I presented to you about bypass surgery?
Yes, please. My question is, as you made mention of bypassing the radial artery, what about the muscles that the radial arteries?
What about what? I'm sorry.
Complication.
From a radial artery.
What about the muscles? Yeah.
I mean,
what about the muscles? Yeah.
What problems you can run into from harvesting the radial artery? Is that what you're asking me?
Yeah, that's my question.
Yeah, the radial artery is really, because the heart surgeons have had a lot of experience, it's very easy. Essentially, before surgery, because you have radial or ulnar artery, you put your finger on the radial artery, you occlude it completely. Then you take a Doppler and put it on the arch that connects the radial to the ulnar. So you occlude the radial and you put it on the arch. If you have good Doppler flow, then you're fine. The other thing is we put a pulse ox on this finger. We occlude the radial artery. The pulse ox is here. As long as the radial artery is occluded for 2 or 3 minutes and you have 100% saturation, you're fine. You can take the radial artery. I've never had a problem, never, ever, okay? It's very easy, and it's actually done by our residents. This is a good exercise. So our first year resident is the one who learns how to do while we're doing the surgery. He's, let me see if I could show you really quick while he comes back in. Let's see. Just to give you an idea. Is Professor Raffa back? Okay, let me share again. Can you see my screen?
Yes.
Yes.
So this is how it's done. So we define our artery. We say, okay, we're going to use the maxillary artery today. This is, we radial the heart. So this is, you see, the whole surgery is done at the same time. So my partner is doing the radial artery harvest. My fellow is opening the craniotomy. My chief resident is doing a small opening in the neck to occlude the carotid artery at the end of surgery. Okay?
Inflating it, make sure
See, that's the radial artery here.
And at the same time,
now the radial artery is being attached to the maxillary artery. Okay? No problem. See, there's very good flow. Boom. Now I'm deciding where I'm going to attach the radial artery. I do this under awake so that I know the patient can tolerate occlusion of the middle.
there, squeeze my hand. Perfect. Let go.
See? Now I'm attaching the radial artery to the middle cerebral artery because the patient is tolerating the occlusion time because the patient is awake. And I'm attaching the here. Okay? And then we
So we actually slide.
so that's really
Excuse me, sir.
yeah. I hope I answered the question.
We
Is
haven't.
Yeah.
Sir, the video was not showing. It was only the slide, the step-by-step small bypass surgery.
Yes.
The video wasn't showing actually.
Oh, the video was not showing. Is Professor Raffa back?
Yeah.
No, let him start, please. It's his time.
No, don't worry. If you want to share the video and conclude your...
Yeah, let me just share real quick, Giovanni. I don't want to take your time. Okay, so
No, don't worry, bro. It was my
one
fault
second.
already to start.
No. Let me show you this. This is important for you to understand. To put your, let's see here. Okay, can you see my screen?
Yes, now, yes.
Okay. All right, so this is what it is. Okay, so we define the maxillary artery. I say, okay, I'm going to use a maxillary artery for this aneurysm. You see, this is a maxillary artery. I'm going to get it here. Good. First, we harvest the radial artery. You see right here. 3 of my team members working all at the same time. So you don't delay. There's not long surgery. Radial artery harvest, craniotomy, and a small opening in the neck to occlude the carotid artery at the end of, once we do the bypass, we occlude the carotid artery, okay? So
We believe
that's your friend, the radial artery, right there, okay?
it decreases.
Now I'm going to attach the radial artery to the maxillary artery that I showed you in that paper, right? How we find the maxillary artery through the craniotomy, and I attach it, okay? You see? Nice flow. I'm very happy now, okay? Now we go to the brain part, all right? Now, to be safe, traditionally this operation is done under general anesthesia. I moved it to awake so that I know that the patient can tolerate, different vessels tolerate different amounts of time. You don't know. There is no technology. So you have to know if the patient will tolerate temporary occlusion of this middle cerebral artery, okay? So I'm going to put a temporary clip here.
Lift her hand.
You see, she's tolerating occlusion because there is good collateral flow.
Perfect. Let go.
Okay. Now I'm going to go ahead while I'm talking with the patient. I'm anastomosing the radial artery to this M2 branch Now I want to make sure my graft is working before we close the carotid. You see, this is my graft. Nice. Maxillary artery. Okay, good. Okay, now we're going to occlude the carotid artery permanently to the right side of the brain. How? But first, temporarily, I want to make sure that my graft is working very good. For 10 minutes, I temporarily close the carotid artery, and we test the patient clinically.
Denver, squeeze my hand again.
Hand,
Denver,
leg,
squeeze my hand real tight.
blood pressure,
All right,
everything.
Let go. Right. Let go. Perfect. Good job. Look at your toes, Deborah. Look at your toes.
See, this is a carotid artery closed, and my graft is the one supplying the brain with blood, okay? Now I close off the carotid artery because I'm 100% comfortable that the IMAX Abdulrauf bypass is working, okay? You see? Carotid artery is closed, the giant aneurysm is gone. This is the bypass right there. Maxillary artery to the MCA supplying the whole brain. The whole carotid artery is closed, the giant aneurysm is gone. Okay, so that's a stepwise. Okay, Professor Raffa is there. Let's please let him have his time. Thank you very much.
Thank you so much. Great case, great presentation, great everything. Thank you, Professor Abdulrauf. It was really worthy also for me to be here. And now I apologize again for my delay. I'm ready now to share my presentation. My presentation will be less interactive. I want to talk about my experience in using preoperative mapping and planning for and even neuromodulation for surgical brain tumors located in eloquent areas. So we know, and we already seen it also in during the surgery showed by Professor Abdulrauf, that awake surgery is gold standard when we want to map and monitor the functions, the motor function, language function during surgery. And of course, we use awake surgery, intraoperative mapping and monitoring for preserving functional network during brain tumor surgery. But we know that the organization of functional networks is really complex and is not always easy to perform our mapping during surgery. We need some time to localize all different networks that we want to preserve. And today in 2026, we have some tools to perform a mapping of the eloquent areas before surgery, just to be more confident during surgery, to be more fast, more quick during surgery in locating the eloquent structures that we want to preserve. And one of these technologies, NTMS, Navigated Transcranial Magnetic Stimulation, that is a technique that merges electrophysiology, neuroimaging, and neuropsychology to give us a preoperative mapping of eloquent structures, for example, of the motor network, of the or the language network. This is the system, and it can allow to achieve such a mapping of the motor cortex, for example, before surgery. And if you compare the imaging achieved by NTMS on the right and the results from intraoperative mapping, you can see that it is not so different, this kind of mapping. So we can achieve the information about the relationship between the tumor and the motor network, the language network, just before surgery. So we can enter the OR being very confident about what we want to do during tumor resection. So TMS anticipates the finding of intraoperative mapping, and so NTMS can allow for a faster recognition of eloquent structures. How it works? It works based on the Faraday principle, in that consists on the use of a coil that is able to produce a magnetic field. The coil is put over the scalp of our patient while he is seated on this chair, and it is able to induce an electric current over the cortex, and using this current we can manipulate the cortical activity and identify the Eloquent structure, for example, the motor cortex. This is an example how we use this kind of technology. We put our MRI scan inside the system, and we achieve the 3D reconstruction of the MRI scan, and then you can see this dipole, that is the coil that is moved over the cortex of the patient. We can see in real time the movement of the coil over the different brain areas, and we can stimulate each single area of our brain just to understand where is located, for example, the motor cortex in comparison with the lesion. And we can use two different types of paradigms for NTMS stimulation. The single pulse stimulation, in which we activate the cortex below the TMS, so we can, for example, activate the motor cortex and use a motor evoked potential that we can record exactly as we perform during surgery. We can also see the twitching of the muscles during stimulations, and these are the motor evoked potential that can be recorded before surgery, so we can be sure that we are activating the motor cortex. And this is the final map with the different color representing different muscles that have been activated by my stimulation. So I can analyze before entering the OR the relationship between the lesion and different cortical representation of different muscles, so I can preserve the motor cortex. What is the accuracy of this kind of technology? There have been a lot of paper published in the literature, but I want to show some cases. These are two different cases with a lesion that could be considered located in the Rolandic area. If you look at the unaffected hemisphere, you can see the omega sign, so you can see the motor, the central fissure. So in front we have the motor cortex. If we look at the affected side, probably both lesions are located close to the motor cortex. Probably the one on the right is a little bit more anterior, the other one is a little bit more posterior. But if we want to know if those two lesions really involved or infiltrates the motor cortex, we can just perform our preoperative mapping using NTMS. This is the final result after our mapping. You can see we have two completely different lesions. On the right, we have a lesion that is infiltrating the motor cortex, so there is a high risk for surgery. On the left, you have a lesion that is posterior to the motor cortex, so it can be approached more safely. It can be resected completely without inducing motor deficits. Those are some more cases. These two slides are coming from the same patient. You can see here on the left the omega fissure. On the affected hemisphere, you can see that the lesion probably involves the motor cortex. So probably this is a high-risk lesion. But if you can see our mapping, you can notice that the lesion is just posterior to the motor cortex. It's very close, but it's not infiltrating the motor cortex. So this kind of lesion can be resected, for example. So the risk is not so high. This is another case, again, two slices from the same patient. Here, probably the omega sign. On the affected hemisphere, the lesion seems to involve the M1, and in the end, our mapping showed that the lesion is infiltrating the cortical representation of the face muscle. So the lesion is involving the motor cortex, and the risk for surgery is very high. But of course, this kind of information is not enough when we have to plan our surgery, because we need to know some information also about the subcortical structures, just to preserve them. And NTMS can be used as a seeding region for the reconstruction of the cortical spinal tract in the case of the motor network using DTI tractography. So we can perform an NTMS-based DTI tractography using the NTMS map as seeding region for the reconstruction of the cortical spinal tract. And this is the final result with the reconstruction of the cortical spinal tract and its somatotopic organization, with the fibers coming from the cortical area with the representation of the face muscles, arm muscles in red, and in green leg muscles. So we can use all this information before surgery to plan my strategy, to plan my surgery, but also during surgery, using this information and putting this information into the neuronavigation system, and using this kind of information just to make our intraoperative mapping and monitoring faster and even safer, just approaching the lesion. When we are close to the motor cortex, we are close to the corticospinal tract, just to orient our intraoperative mapping and trying to preserve as much as possible the eloquent structure. This is another case. A lesion that you can see here seems to be anterior to the right motor cortex, but if you look at the sagittal plane, you can see that the deeper portion of the lesion goes backwards, so it probably involves also the corticospinal tract. This is another case, recurrent high-grade glioma. The lesion probably involves the motor cortex, so both lesions are motor eloquent, but when we perform the preoperative planning based on our NTMS mapping and DTI reconstruction of the entire motor network, you can see there is a huge difference between the two cases. In the first one, in the left, the lesion is dislocating the corticospinal tract, but is not infiltrating the corticospinal tract, while in the second case, the lesion is infiltrating the corticospinal tract. So in the first case, we can try to resect the lesion, trying to preserve the corticospinal tract, so the risk is high. But in the second case, we already know that we cannot resect all the lesion because it is infiltrating the motor tract. So the resection will be much more difficult, and risk of postoperative deficit, of a worsening of postoperative deficit, because this kind of patient has already a motor deficit, is very, very, very high. So all this information can be used to stratify our patient, to plan our strategy, and to improve also our surgeon and our intraoperative mapping. This is another case. Usually expert surgeons say that they can easily locate the M1. This is true, but there are some cases in which there is a huge edema, so it's difficult to identify the central fissure, to identify the motor cortex. Like in this case, you can see this lesion, a huge peritumoral edema. We don't know exactly where is the Rolandic fissure. Probably it is here, and the lesion is anterior, but we need to verify. And this is the preoperative mapping locating the motor cortex. And once we have all this information, we can reconstruct the motor network, and we can realize that the lesion is anterior, yes, but it's close to the corticospinal tract. So the risk for resection of this lesion is high, but we can manage this surgery using intraoperative mapping and monitoring. And we already know before entering the OR which is the real relationship between the lesion and the motor network, so we can be more confident and more effective during the resection. This is an example of the planning our surgical strategy to reach the lesion, trying to preserve the corticospinal tract. Another case, take a look here. I showed you before. This was the case of the lesion that was infiltrating the motor cortex. This is the preoperative on the right reconstruction of the relationship between the lesion, the motor cortex, and the vascular structures. This is what we have seen before entering the OR. You can see here the lesion in white, the indicated by the asterisk, the white spots that are the NTMS spots, the motor cortex represented by the letter M. And this is what we observed during surgery. Take a look at how it is accurate. You can see the same huge venous vessel here posteriorly. You can see this small, tiny vessel here. You can see the motor cortex. The asterisk corresponds to the lesion. So we can enter in the OR, see what we have already seen in the preoperative planning, perform our mapping, our monitoring, and resect the lesion, trying to be more safe and more effective as possible. This is the preoperative planning, again, showing the relationship between the lesion, the NTMS cortical spot representing the motor cortex, and the corticospinal tract. This is what we performed during surgery, our preoperative mapping, opening the arachnoid, and then resecting the lesion under the guidance of the intraoperative monitoring, using also 5LA and so on. And this is the patient that experienced an early postoperative motor deficit that was recovered after 1 month. This is the other case that I showed you before. This is the planning. You can see the relationship between the lesion in yellow and the corticospinal tract. Again, the planning. And this is how we manage this case using our navigation to verify the relation between the lesion that is here in yellow because we use the sodium fluorescein and the interfaces with the normal brain indicated by the red arrow. And this is the post-operative MRI scan, and this is the patient without post-operative neurological deficits. So now I want to show you what literature say about the accuracy of the NTMS mapping for the motor cortex. First of all, in comparison to other preoperative techniques, like, for example, the functional MRI, there are many papers. This is a meta-analysis showing that the NTMS is more accurate than functional MRI. And you know that functional MRI is really very diffused in different neurosurgical centers, while NTMS is just approaching in neurosurgery. But since NTMS is a neurophysiological technique, it is more accurate than functional MRI. And even the reconstruction of the entire motor network using this kind of NTMS-based planning is very accurate in stratification, in the stratification of patients with a motor eloquent lesion. So if you found a lesion that is closer than 80 millimeters from the motor network, of course, the risk for postoperative permanent motor deficits is really high. And this is another systematic review that we performed a few years ago, in which we found that in the end, literature demonstrates that the NTMS motor mapping reduced the occurrence of new postoperative permanent motor deficits as compared to surgery without using NTMS preoperative mapping. Of course, we use intraoperative mapping and monitoring, but if we add NTMS preoperative mapping and planning, we can reduce the occurrence of postoperative motor deficits and even increase the extent of resection because we are more confident when we enter. The second paradigm that we can use is the repetitive simulation, in which we perform a simulation consisting in a train of stimuli, and using this kind of repetitive simulation we can induce a transient virtual lesion over the brain cortex, so we can create an inhibition of the cortical areas that we are stimulating. And we can use this kind of paradigm to study cognitive function, including, for example, language. So the patient is asked to perform a task, for example, an object naming task if we want to study language. And then we start our simulation and we can inhibit the language network. So the patient is not able anymore to name the object that he or she is watching on the screen. So we can locate, using this kind of approach, using repetitive NTMS, the location of cortical language essential sites, and we can achieve our map before surgery, in which you can see those spots that are surrounding the lesion but are not located over the lesion. So again, this kind of information can be useful to plan our surgery. What about the accuracy of this kind of approach? The interpretation of evidence is a little bit more complicated than for the motor cortex. There are different results reported in the literature. You can see this is a systematic review showing that the sensitivity, specificity, positive and negative predictive value are reported with different percentage. But if you see the negative predictive value, it is usually very, very, very high. This is another study from the MD Anderson Cancer Center showing that the language mapping using NTMS is more accurate than functional MRI as compared to the gold standard direct cortical stimulation. And again, the negative predictive value is very, very high. This is another study from my colleagues and friends from Berlin, where they found again that the NTMS language mapping has a very high negative predictive value. That means that if we perform an NTMS language mapping before surgery, we don't find any language cortical eloquent sites. That means that we can resect that area because that area is not involved in the language network. This is similar to what has been reported in 2008 by Sanai and Berger with the famous negative language mapping. When we are in the OR, we found a negative mapping during wake surgery. We usually go on and resect that area, and the same can be said for the NTMS language mapping, because the negative predictive value is very, very, very high and is comparable to the findings of the intraoperative negative language mapping. Again, even for language element lesion, we need to verify the organization of the subcortical structures. This can be much more complicated than for the motor cortex, but it can be done using the NTMS spots as seating region. And again, we can use this kind of mapping to stratify our patient and calculate the risk of postoperative language deficits according to the distance from the main fascicles, for example, from the arcuate fascicle. And if we use this kind of approach in our everyday clinical practice, so if we perform our NTMS language mapping, we can really predict the occurrence of postoperative language deficits. Moreover, this kind of approach can be used to study other functions, for example, visuospatial abilities using different tests, not a standard object naming task, but for example, some tests like line bisection test, Uber test for the identification of the cortical areas involved in our visuospatial skills. We can use again DTI cartography to identify subcortical structures involved in the visuospatial network, for example, the superior longitudinal fascicle. And we can use all this information again, as we have done for the motor network, for the language network, to preserve the visuospatial network and reduce the occurrence of postoperative neglect that usually is evaluated by neurosurgeon, but it's very important for the life of our patients. So, summarizing what I have told you since now, the NTMS preoperative mapping and planning can be used, first of all, to identify the spatial relationship between the lesion and the eloquent networks, the cortical areas, the subcortical structures, that allow us to stratify patients according to the risk of developing postoperative motor or language deficits. And all those information can be used during surgery to improve the results of our surgery, in conjunction, of course, with the intraoperative mapping. But if we are aware of what we are doing in the OR just before entering in the OR, we can be more confident, we can have a faster and safer intraoperative mapping and monitoring, and that can result in an increased extent of resection and in a reduced occurrence of postoperative motor deficits. So this is the workflow that I follow in my clinic every day. When I identify patient with a lesion in a suspected eloquent area, I perform my NTMS preoperative mapping and planning, trying to understand if the lesion is really involving the eloquent networks or not. And then we decide if we want to perform a wake surgery or not. Of course, if the lesion is really close to the language network, for example, we can decide to go with a wake surgery. This is very important because we have a preoperative demonstration that the lesion is close to the language network thanks to the NTMS preoperative mapping. So we can be sure that awake surgery will be really helpful in that patient. Or when we disclose a safe location of the lesion that is far away from the eloquent structure, we can go with our sleep surgery using, for example, only intraoperative mapping monitoring for lesion that are close to the motor network, just to be sure that we are doing the right thing. This is our experience for different kind of lesion, not only brain tumors, so only, for example, cavernous angiomas, also AVMs. And yeah, now I want to show some other cases. Again, this is high-grade gliomas, probably involving the motor cortex. This is preparative mapping. Again, the lesion is posterior to the motor cortex, so it can be safe to go and resect this lesion without inducing postoperative motor deficits. This is the relationship with the corticospinal tract, and this is what we have done during surgery. Of course, we have our intraoperative monitoring. We have our preoperative mapping. We are used to perform fluorescence-guided surgery. We use the navigation to verify the relationship with the lesion, and since the lesion was very, very close to the motor cortex, we performed surgery. We performed also a WEG surgery, and after we performed again the intraoperative mapping, we went on with our surgery, and we performed our resection until achieving the gross total resection of the lesion. This is another case for language eloquent tumor. You can see here the mapping that I showed you before. The lesion is surrounded by cortical eloquent spots and is close to some important language factors. So we went with surgery using our information during surgery to perform a faster and safer surgery, and in the end the resection was complete with no postoperative language deficits. Of course, there are some patients in which WEG surgery should be indicated, but for some reason WEG surgery is not feasible. For example, it's very difficult to perform a WEG surgery with children or older patients with a glioma because they can be disoriented, they are not cooperating during surgery. There can be also some patients with a psychiatric disease, so it's not easy to perform a WEG surgery. On all those situations, we can use our NTMS mapping and planning to perform our surgery. It's not imaginable to perform just standard sleep surgeries as we performed 20 years ago. Today we have some tools like TMS that can provide us preoperative functional information that can guide our surgery, and that can be used in cases like that when a WEG surgery should be indicated but it's not feasible. For example, this is a picture of a child. This is another case of an older guy that was not eligible for a WEG. The lesion is quite posterior, but is close to the TPOJ, so there could be some relation with the language fascicle. This is the language mapping, and this is the relationship between the lesion and the arcuate fascicle in orange. You can see the lesion is very, very, very close, so probably a WEG surgery could be indicated. You can see here in the axial scan, the lesion is very close to the vertical portion of the arcuate fascicle in orange, but the patient was not eligible for WEG surgery, so we performed a sleep surgery, and everything was performed using the guidance of our neural navigation and our preoperative NTMS mapping, and this is the final result. The postoperative MRI scan showed the complete resection of the lesion, and the vertical portion of the language of the arcuate fascicle was completely preserved. So in this case, even if we perform sleep surgery, the use of NTMS information was really useful to avoid the occurrence of postoperative language deficits. We analyzed our results in all those patients that were not eligible to a WEG surgery, and we analyzed the occurrence of postoperative permanent language deficit. That was in our series of 176 patients, 7.3%. Is not that high, is not that low, is not comparable with a WEG surgery, even if there are many papers reporting different percentage of language deficits after WEG surgery. Anyway, consider that all those patients were not eligible to a WEG surgery. 7.3% for postoperative permanent language deficit was, in my opinion, a good percentage. And the gross total resection was 80%, that increased to 100% in all those cases that were considered not eloquent after performing NTMS preoperative mapping, so after the stratification that we performed using the information provided by the NTMS mapping. And now the last question that I want to talk about is a novel aspect of the use of NTMS in our neurosurgical patients. There are very recent evidence that the connectivity around the brain tumors has a fundamental role in the spreading of the gliomas. So usually there is this paper published on JAMA, in which it is demonstrated that the higher is the connectivity in the peritumoral area surrounding the glioma, the lower is the survival of patients. So high connectivity seems to have a role in the spreading of the of glioma, because there is some that they call neuroglioma network that can influence the spreading of the glioma. So this paper found that, as I told you before, a low connectivity around the lesion is associated with an increased overall survival. This is a very important information. So we decided to try to exploit these new results using our NTMS to modify the connectivity around the tumor in our patient. This was not our original idea. There are some papers like this one published by one colleague from Spain that used direct cortical stimulation to try to modify the connectivity around the gliomas to improve the efficacy and safety of the second resection. I want to show you what they found. They performed the first surgery during a WEG surgery. They performed intraoperative mapping. They found some spots that were really eloquent, so they were not able to resect some portion of the tumor. So they left some remnants of some residual tissue of the glioma, and then they put a subdural grid and started stimulating the cortical areas with a subdural grid for 2-3 weeks. Then they performed the second WEG surgery. They found that those areas that were eloquent during the first surgery, after the neuromodulation performed using the subdural grid, were not more eloquent, so can be resected. You can easily see this in this picture. You can see here in this case there are some red spots that were eloquent and were not resected. After stimulation, they became yellow, and they were then resected without the occurrence of postoperative language deficits, and so on, also in the other cases. So this paper highlighted the possibility to use neuromodulation using subdural grid for improve the efficacy and safety of our surgery. But of course, there are some complications related to this kind of procedures, because you understand that if you use subdural grid, there is a very high risk for infection. The procedure is really invasive. There is the risk of malpositioning, of developing subdural hematoma. So there are a lot of complications. So from there, there is the idea to use non-invasive stimulation to try to induce this kind of connectivity changes and improve the efficacy of our surgery, and try also to influence the evolution and the natural history of gliomas. For example, a great colleague that you for sure know, Dufort shares with us. This is an editorial that he wrote for a monothematic issue. I invited him to write this editorial about this idea, and he was absolutely in agreement with me that probably non-invasive stimulation can be used to improve a second surgery in glioma, in low-grade glioma patients. We over the year trying to verify if we can induce this kind of connectivity changes in our glioma patient, and if this kind of approach is safe. And we published this paper in which we found that we can safely use this kind of neuromodulation using TMS in our patient affected by motor eloquent tumors using two different patterns, one in which we perform our stimulation once a day for 14 days, and the second paradigm is stimulation twice a day for 7 days, and it was really well tolerated. So I got funded from European Union to perform 2 studies trying to investigate the possibility to induce connectivity changes using NTMS in brain tumor patients, and trying to assess if this can impact the extent of resection, the occurrence of post-operative motor deficits, and even the survival of patients. And we are working on that. This is the protocol of one of these 2 studies in which we compare 2 different NTMS strategies, one based also on EEG, and then we randomized our patient in 2 groups, one in which we performed the NTMS stimulation and the sham group in which we didn't perform any kind of stimulation. And then we assessed the connectivity changes, the EOR, and the post-operative deficits. We used this kind of parameters for our stimulation. So repetitive stimulation, 1 Hz, 800 pulses for 7 days, 30 minutes each session, twice a day. And we analyzed our connectivity changes. We analyzed seat-based connectivity, ROI to ROI connectivity changes, interhemispheric connectivity changes, and now we are assessing the extent of resection and post-operative deficits. And this is the first step that we analyzed, comparing pre and post NTMS stimulation. We observed a significant change in connectivity between the motor cortex and the global brain. I say again, here you can see on the left the pre-stimulation connectivity, and on the left, on the right, sorry, the post NTMS. You can see the motor network here on the right. Consider that the functional MRI images are inverted as compared to standard MRI. So you will have right here and left here. You can see the right motor cortex is less connected to the rest of the brain. This is a case of the patient that is close to the motor tract. You can see here the connectivity changes, say, between the right M1 and the global brain. See here, pre on the left and post on the right. You can see that there is a blue increasing over the lesion. That means that the right M1 has a reduced connectivity to the area surrounding the tumor. So this is a first result. Then we analyze connectivity between the left M1 and the global brain. Again, you can see after stimulation, there is a reduction of the connectivity of the peritumoral areas. You can see here surrounding the lesion, while there is an increase on the left of the connectivity of the left M1. So the left M1 increases connectivity with the rest of the brain, but reduced the connectivity with the peritumoral area. Again, another case, low-grade gliomas involving the left M1. You can see here before and after. The tumor is here. You can see after stimulation there is a very blue areas in the peritumoral region. That means that there is a reduction of the connectivity. It was significant. And again, Same cases, connectivity between the left M1 and the global brain. Again, you can see here, after stimulation, there is a blue signal over the tumor with a reduction of the connectivity, while the right M1 is increasing its connectivity with the rest of the brain. So our stimulation seems to reduce the connectivity in the peritumoral areas, even if we are stimulating the contralateral M1, while the ipsilateral M1 is increasing its connectivity. This is the another analysis of connectivity, the arrow Y to arrow Y connectivity changes. That is again reduced after our stimulation. You can see here the SMA that is no more red here because there is a reduction of the connectivity. And this is an analysis of the connectivity between different brain areas and the peritumoral area. You can see pre and post stimulation. There is a lot of changes, especially a reduction in connectivity. So our NTMS was able to modify the connectivity of the brain, and this is the third aspect that we analyze, the interhemispheric connectivity. You can see pre and post. There is an increase of the connectivity of the interhemispheric connectivity between the two motor networks. So in the end, the results of our simulation was that there was an increase of connectivity between the unaffected M1 and the rest of the brain, while there was a reduced connectivity between the cortical M1 and the peritumoral area. So we were able to reduce the connectivity surrounding the tumor. That could be really, really, really interesting. This is an example of those cases that then we operated, of course, using also the NTMS-based preoperative mapping and planning. So we performed our NTMS motor mapping, language mapping, and also our DTH cartography of the language fascicles. And this is just a CT scan showing the resection of the lesion. We are waiting for performing the MRI scan. This is another case that I showed you before in the analysis of connectivity. And of course, the lesion was completely resected without post-operative deficits. So in conclusion, the NTMS planning, mapping planning is very helpful to identify eloquent areas, language, motor areas, and it is able to allow us to stratify the risk of our surgery and to improve our confidence with the relationship between the lesion and the eloquent structures. That allows for a safer resection, reduction of postoperative motor deficits, and probably, as I show you in the last slides, neuromodulation is the new frontier for this kind of application, because we can probably modify the interaction between the tumor and the surrounding brain. That can allow us to improve our extent of resection, reduce the occurrence of postoperative deficits, and probably also to influence the natural history of the brain. But we are still verifying this last point with our studies. Thank you. Thank you so much.
Really a beautiful presentation, Professor Raffa. Just so much science, great stuff. Really, the future of brain tumor management, with the neurosurgeons taking a lead from that standpoint.
Thank you so much, Professor Abdulrauf.
Yeah, of course. Giovanni, I want to ask you a question, because some of the students here don't see this stuff all the time. Just for them to understand better, for stimulation of function versus inhibition of function, whether a patient is awake or under general anesthesia, which functions do you stimulate for? Which functions do you aim at inhibition of the function? And how do you decide that?
So this is a question for students.
Yes.
Of course. So if we want to stimulate and activate some function. The classic example is the motor function. So you during a wake or during a sleep surgery, because usually for lesion close to the motor network, surgery is performed during a sleep surgery. You can just put your electrodes over the motor cortex and perform our stimulation, and then record the motor evoked potential on the peripheral muscles, and you can monitor those MEP. And when this allows you to start your resection while monitoring this motor evoked potential. And if you look that there is a decrease of the motor evoked potential, that means we are really close. There is a risk of permanent damage and permanent postoperative deficit. So you have to stop. So the motor function is the example of a function that can be activated, and then we can record the activation of this function. Other functions that are more complex, like the language, for example, cannot be monitored during a sleep surgery and require a wake surgery, even if there are some papers in which some authors are starting to introduce some new novel methods for the monitoring of the language function. The gold standard for language function is a wake surgery. During a wake surgery, we perform our test. We decide the test according to the function that we want to study. So if we want to study language, we can choose easily an object naming task. The patient is asked to name the pictures that we are showing to him or her. And then we perform our inhibitory stimulation using our probe over the language cortical areas, over what we suppose to be the language cortical areas. And when we notice an error during the performance of the task, we are then sure that that point that we are stimulating, that we are inhibiting, is involved in the language network, and we have to preserve. We can put a small letter over that point, so we can remind that we should not touch that area, and we can move in another area. And after we perform our cortical mapping, we can start our surgery, alternating resection and stimulation of the subcortical structures, because we want also to verify if we are close to subcortical structures that are really fundamental for language. So if we look again, an inhibition of the language function, that means an error during the performance of the object naming task, we have to stop. When you perform this kind of surgery, you need a neuropsychology or a speech pathologist if you want to study language. But if you want to study other functions like visual spatial abilities, executive functions, more complicated functions, you need a neuropsychologist that will suggest to you the task to be used during surgery. The neuropsychologist will administer the task to the patient, and you will perform your surgery. But the mechanism is the same. If there is an error during the task, you have to stop, because that area is involved in that function. Okay?
Very nice, Giovanni, for you to explain to the students, because a lot of them have never been in the OR, and for them to understand why do that. The other just quick thing, Giovanni, if you could explain to them, why would stimulation lead to decreased connectivity? I'm sure a lot of them is asking this question in their head.
I don't know. I don't know because our original idea was to perform our NTMS stimulation and to increase the connectivity on the contralateral hemisphere, and we wanted to assess if that could in some way protect the affected hemisphere during surgery and allow the affected hemisphere to be more compliant with our aggressive surgery, so trying to reduce the postoperative motor deficit. But in the end, when I analyzed the images, I noticed that we had an unexpected result, that was the reduction of the connectivity just over the preoperative over the peritumoral areas. It was completely unexpected for me, so I went down from my chair because it was unexpected, because I could even achieve a reduction of the connectivity in every other part of the brain. But if you took a look at the picture, it was really close to close to the tumor in the peritumoral region, and we are now in the phase that we are assessing what it means really, and if it can have an impact on the natural history of the tumor. It is very interesting. That's the reason why I do research.
Beautiful work, Professor. What you guys see here, and Professor Raffa, you see, this is what we're trying to achieve. We want neurosurgeon scientists, right? So people who have clinical practice, same time using every surgery, everything to improve our field. This is the ultimate example of the physician scientist model, which is really fits neurosurgery, probably any other specialty, but explains what kind of mentors you need. And he is the kind of mentor that you would want to help develop that kind of career and how you think. Thank you so much, Giovanni. Beautiful work.
Thank you all for the invitation. I'm really happy to talking of the students. We are not professor. Our life is dedicated to students. So I'm very, very, very happy every time I can have a talk in front of students.
Thank you very much, Professor, for this insightful and inspiring talk. We truly appreciate your time and the valuable knowledge you have shared with us today. We will open now the floor for questions. If anyone have a question, please feel free to raise your hand or write in the chat, and we will be happy to go through them. Dr. Adamu, please. No one has a question?
Hello, Shad. Can you hear me?
Yes, I'm hearing you.
Okay, thank you very much, Professor, for this wonderful presentation and lecture. As we as medical students, this is almost the first time we are hearing about this. We have heard about brain mapping before, preoperatively, but this one is an eye-opener to us. My question is that for the preoperative brain mapping, so if tumor, for example, a glioblast, a tumor is there, so we need to not to resect or minimize the resection or something like that if it affects the major area with, for other activities. Thank you very much.
Sorry, the audio was disturbed. Is everyone able to report the question, or if you want to, you can write it in the chat. Adamu.
Hello, sorry, sir.
Yes, please. Can you repeat, because the audio was disturbed? So you.
Please repeat the question for him because we could not hear you.
Okay, sir. I'm asking about the operation. Because of network, let me write it down. Let me write it down. For example,
write it down. Your connection is poor. Write it in the chat, please.
Yeah, please.
Let's take another question until Adam writes his question. Oswala.
Yes, thank you very much for this presentation. I actually have some couple of questions to ask, but I would really love to know if a surgery is being performed and there is a tumor at a side of the brain and the tumor overlaps other eloquent areas? Are there eloquent areas that you give more preference over?
So,
Hello?
yeah. Are you asking what to do when there is a recurrent glioma involving the eloquent areas?
Yes, sir. Are there eloquent areas you would give preference over in that type of surgery, sir?
Again, even when there is a recurrence, we perform again the preoperative mapping, planning, just to understand if there is an involvement of the eloquent areas. And then we use the same approach that I showed you during the presentation. It is useful both when there is the first diagnosis or even when there is a recurrence of the brain. Even during recurrence, during surgery for recurrence, we have to preserve eloquent structures. So everything we can do to preserve the function and ensure a good quality of life to our patient must be done. So we have to do everything we can do to improve the quality of life of our patient after surgery, even if it means that we have to leave a portion of the tumor, because after that, the patient will have the possibility to perform adjuvant therapy, chemotherapy, and radiotherapy. But if we, for example, resect completely the tumors and after surgery the patient is hemiplegic, the hemiplegic patient will not be able to perform adjuvant surgery, and the overall survival will be reduced. So our aim is to guarantee a good post-operative functional outcome, so the patient can perform adjuvant chemo and radiotherapy, and that increase his life expectancy and survival.
Thank you very much, sir. Thank you very much. I actually have one more question left, and I would really love to know, because I've read something and heard something about plasticity in hemispheric stimulation and plasticity in pediatrics at young age, in which there is a tumor at an eloquent area in the language eloquent area, and they're able to like transfer plasticity from one side to the contralateral side of the brain of the patient, in which the patient is able to talk even after resecting the tumor on the other side. So what's your take on this, and are there evidences to support this?
So plasticity and connectivity is a very serious matter. Still today, we don't know exactly how it works. We know that every kind of stimuli can induce neuroplasticity and modify the organization of the brain. That means that also surgery can induce modification in plasticity and induce new connection in the brain. In children, especially, connectivity and the potential for plasticity is very, very, very high. Anyway, it doesn't necessarily mean that if you resect the lesion on the left brain Broca areas, for example, that is the area for the motor part of language, the patient will be able, thanks to neuroplasticity, to speak again after surgery, after some time. We are not at that point. And we are studying about how neuroplasticity can be useful in recovery from post-operative deficits. But of course, in children, the potential for recovery thanks to neuroplasticity is higher than in adult patients.
Okay, sir. Thank you very much, sir. One more question.
Wait. Adamo wrote down his question. He wants to know. The question has been asked by current speakers. Okay, so Oswala, you can go on with your question if you want.
Thank you very much, sir. Sir, yes, I want to ask about neurostimulation and brain mapping for patients that have neuropsychiatric problem. Has that been done by you? And how is it like? Because in your presentation, you said you can't do, or awake craniotomy is contraindicated in patients that have psychiatric problems. So how is that going to be done?
No. I said that in some cases, patients with psychiatric disease cannot be considered eligible for awake surgery. That means that awake surgery is a complex, is a major surgery. And if you want to have a good result during awake surgery, you need a good cooperation from the patient. If you have a patient who suffer from a serious psychiatric disease, so for example, a serious anxiety disorder, and the patient is not able to cooperate during surgery, you will have a failed awake surgery. Because if you want to see, if you want to understand, if you are close to the language area, the patient must perform the task correctly. If the patient has a serious anxiety and cannot perform the task, your awake surgery is absolutely unuseful and become a failed awake surgery. So you have to select patient. If there is some patient who cannot cooperate during surgery, automatically that patient cannot undergo awake surgery because it will be resulting in a failed awake surgery, at least in my experience. That means, for example, I said also children. It's difficult to perform awake surgery in children, but of course it depends. If you think you can have a good cooperation from a 10-year boys, you can try to perform awake surgery. That doesn't mean that all children cannot undergo awake surgery. It depends, but you have to perform a very careful evaluation, even using a neuropsychologist, to understand if you will have a good cooperation during surgery, or if there is the suspect that you cannot have any kind of cooperation. In that case, at least in my experience, thanks to also to the information provided by the NTMS mapping, I prefer to use my NTMS mapping and perform a sleep surgery instead of having the risk of a failed awake surgery.
Thank you very much, sir. Thank you very much.
Marwan?
Can you guys hear me?
Yeah.
Yes.
Okay. Thank you, Dr. Givani, for this amazing presentation. I really liked it. I have a small question regarding deep tumors near the brainstem, regarding motor potentials, if I remember correctly. Can NTMS also and somehow be used for it, or?
NTMS can be used for mapping only cortical areas.
So not for deep.
No, because I show to you at the beginning of the presentation, we have a magnetic field that is created by the coil that is applied to your scalp. And this magnetic field is able to induce an electrical current over the over the cortical areas. It's not able to reach the deeper portion of the brain. Absolutely not. You can just map cortical areas.
Okay, thank you.
Just complexity, it's difficult. Of course, you cannot map cortical areas of the skull base or that are in front of the skull base, or you cannot perform a precise mapping of the interhemispheric cortical areas.
Okay, thank you. Just another small question. The data that you get from NTMS, I heard that it can be used to get diffusion tensor imaging to get the mapping of subcortical tracts or the corticospinal tracts?
Yes, I showed to you that NTMS cortical areas can be used as seeding region for the computation of the DTI tractography of the corticospinal tract or of the language fascicles, but are two different techniques. NTMS is a neurophysiological technique. DTI is acquired during the MRI scan. Then you can merge both images and create your NTMS-based DTI tractography.
Oh, so by merging. Okay, thank you.
Okay,
Thank you.
you're welcome.
Yeah.
Okay, hello everyone. Is my voice clear?
Yes.
First of all, I'd like to thank both Professor Saleem and Professor Giovanni for this valuable insight that they have shared with us today. And honestly, I have a little question related to the NTMs, as it's mainly concerned with mapping of preoperative mapping of the cortical lesions, as Professor Giovanni already mentioned. My question is, if the margins of the lesion, for example, say it's a tumor, if the margins are related, or part of the margins are related, or one of the motor tracts related to the language or related to the motor control is passing through the margin. I don't know if you can get my point, but if the margin of the tumor is intermingled, or the tract is passing through part of the margin, not all of it. So what would be the clinical decision? I mean, the margins or the area of the margin around the lesion or the para-lesional side, that's the signals may be false positive, false negative, and so on. This will affect the clinical decision. For example, taking this margin or taking a safety margin and risking the area around there. Or do you got my point?
Yeah. So when you perform your preoperative mapping, you can visualize if the margin of the lesion are infiltrating or not the motor cortex or the corticospinal tract. That is an information that give you the idea that the surgery will be at higher risk of inducing postoperative motor deficits. So that's the reason why you will perform during surgery the gold standard, that is intraoperative monitoring and intraoperative mapping. So during surgery, you will verify using your simulator if the lesion is infiltrating or not the motor cortex. If you realize that the lesion is infiltrating the motor cortex, you will leave that portion of the tumor infiltrating the motor cortex there without removing it, and you will resect the remaining part of the tumor, because the objective is, of course, to resect the tumor, but we have to achieve a maximal safe resection. So we can resect only what is safe. We don't want to create an hemiplegic patient, because if we induce a permanent motor deficit, if the patient will be hemiplegic after our surgery, it will be not able to perform adjuvant therapy, and that will result in reduced survival. The concept of brain tumor surgery is different from other type of tumor surgery outside of the brain. It's not like the liver tumors, in which you have to resect as much as possible and have a free margin. In brain tumor, you have to perform a maximal safe resection. Took out, everything can be resected. If there is some portion of the tumor infiltrating the motor network, you have to leave there that portion of the tumor, and then the patient will undergo adjuvant therapy. Is it clear?
Yeah, it's clear right now. Ready. Thankful.
Thank you all for your thoughtful questions and active participation. Once again, Professor Giovanni, thank you for joining us today and for your valuable contributions.
Thank you, you all.
Professor Thomas, are you there? Unfortunately, Professor Thomas was unable to join us. We hope to have the pleasure of welcoming him in the future session. We appreciate your time and participation and engagement. Have a wonderful day. Thank you once again for joining us. Bye.
Thank you. Bye. Bye, Professor Abdulrauf. See you in the next one.
Great to see you, Giovanni. It was great to see you. Yeah, same here.
Bye.
Bye.